afternoon. My name is Temilade and you're welcome to my YouTube channel. If you're a returning subscriber, I want to say thank you. Please do not forget to like, comment and share this video. So in today's topic, I would like to talk about congenital disorder in neonates. So neonates are the newly born babies. And the first thing is the musculoskeletal disorder. That is the skeletal system. Musculoskeletal disorder, these are the disorders of the muscles and skeletal system that affect the movement of human body. And the first under this musculoskeletal is talipes equinovarus. Talipes equinovarus is also known as club foot. I'm going to be putting the picture just for you to see what club foot look like. And it is most common disorder of the foot. It can be unilateral, which is the most common, and bilateral. The deformity of the foot, where this talipes equinovarus or club foot. I'll just be using club foot very well. The club foot is the deformity of the foot. The deformity of the foot where the foot is bent forward, that is plantar flexed, and the frontal part of the foot is turned inward. And this club foot, it affects the male more than the female. The causes for this club foot, it is idiopathic, that is, it is unknown, but there are some predisposing factors that can make a child to have this club foot. That is, when the mother is pregnant, maybe she was exposed to some teratogenic agent like thalidomide. Although the drug is banned now, but I don't know, maybe some people still have it, but it's very bad. It is a teratogenic agent that can cause a lot of deformity for a growing fetus in utero, or in a family or a mother that has spinal bifida, or maybe there is a family history of club foot. Some people will say they don't have this one in my family, they don't have that one in my family. You never can tell, generations have passed, so that is not occurring in the present generation does not mean maybe it has not occurred before with the past generation. Treatment or intervention for this club foot, the best thing is early detection, so that they can start prompt treatment as early as possible. So treat as early as possible after birth. Then you sort for orthopedic surgeon. Orthopedic surgeon advice is the best. Immediately you detect that at the early stage, don't take your baby to a teaching hospital or hospital nearby, so that a surgeon advice can be sought. If sorted early, they can splint the foot or manipulate the foot sort of, so that there will be minimized or reduced surgery. So if correction is achieved within the first 6 months, mother is advised to alternate footwear, that is the slippers or the shoes that you wear for your baby. You will alternate it, the left to the right and vice versa, just like that. And also, if available, a Dennis Brown splint should be worn at night. That's if available. If the mother is financially capable to get a Dennis Brown splint, you can also put that on the leg of the baby. It will really go a long way. And why in resistant cases where surgery cannot be done, where everything is just after manipulation, after splinting, is just proving difficult, then a surgery is done. So the next one I'm going to be talking about is amelia. And this amelia is a birth defect of absence of one or more limbs, either the upper or the lower limb. And the causes, like I said earlier on, the causes sometimes they are idiopathic, but for this one, there is interruption during the early stage of pregnancy, between the 24th to the 36th day of following fertilization. That is why it is advisable that whenever a woman taking. Do not take any medication, do not use anything at the first trimester. If you are sick or you need any attention, go to the hospital, because at that time, I used to say, you never can tell which part of the baby is developing. Any part that is developing will be the one to suffer will be the one to suffer for your consequence. And another causes can be complications during early stage of pregnancy, like maybe there is infection, maybe there is a failed abortion or incomplete abortion, maybe the woman is exposed to tetragenic drugs. I keep on saying it, thalidomide. They are very, very bad. I heard it is banned already. So management for this amelia is, there is no special treatment for this amelia, because when there is absence of one or more limbs, there's no special treatment that they're going to do. Then they should just build a prosthetics for the baby to use, so that the baby will just learn how to use it right from time. And also psychological support is very, very important for the woman, for the family. You have to encourage the woman have to be strong for the baby, have to protect the baby against danger. Do not leave the baby alone. Protect the baby in school against bullying and everything. Make the baby special. Let him or her know that even without a limb or without the fingers being not present, he or she can achieve certain things in life. So next is phocomelia. This phocomelia, there is normal hand and feet, but there is absence of long bone. Just like the normal baby we see around, the normal people we see around with the normal hand, normal fingernails, everything. But just in this case, there will be normal hand, there will be a normal hand of the upper limb then, but it's just that the long bones will not be there, will not be present. And this phocomelia is a very, very rare condition, and causes is unknown, but there are some inherited genetic syndrome. A gene is very, very powerful, is very strong, is transferable. So never can tell which one a person has inherited from his or from her father, or from his father or her mother. So the predisposing factor for this phocomelia is a mother that has been exposed to thalidomide, that's the tetragenic agent, a mother with gene problem, or exposure to some viruses. There are a lot of viruses that can make the baby to be prone to have congenital anomalies. So now, treatment for this phocomelia. Treatment is with the use of prosthesis, or prosthesis could be an alternative for the missing limb. So phocomelia and amelia, there is no treatment, there is no surgical intervention that can be done except for the use of prosthesis. And another thing is polydactyly. Polydactyly is also known as supernumerary digit or extra digit. This is very, very common in our environment. Even while growing up, I saw some babies, some grown-up adults with supernumerary, that they left it like that. So supernumerary is extra digit, which occur either on both hands. It can occur in the left or the right hand, and also it can also occur on the feet. Incidence. For the incidence, this occur as a skin tag on either the both hands. So treatment for polydactyly is ligation of the skin tag. So even at birth, when examined and there is no bone noticed, they will just look for a rope and tie it. So necrosis will occur, there will not be blood flow to the place again, and it will be necrotized and ischemic and all this kind of thing. It will fall off. So also the surgical intervention for polydactyly, if there is a long bone noticed, is amputation. So if a long bone is noticed, they will amputate the syndactyl. Syndactyl is just in the same class with polydactyl. So syndactyl is an abnormality of the upper extremities and feet with an abnormal fusion of the digits, either partial or completely. So it may consist of interdigital webbing of the skin only, or bony structure or bony structure or both. So I'm going to be leaving their pictures so that you can see what they look like. So incidence, it mostly affects the third and the fourth fingers and second and third toes. That's for the leg. And the causes is hereditary factor. All these causes, as far as it is congenital, it will be dealing with genetic, hereditary, thalidomide, all sort of. It will be dealing with them. And the treatment for this syndactyl is surgical operation, so that they can lose the web or whatever they want to do is surgical. They can't manipulate, they can't splint, there's nothing they can do to that one except they go surgically. Moving on, the next after skeletal system is gastrointestinal disorder. I know a lot of people will be saying, what concern mouth with gastrointestinal tract? Actually, I used to tell people that digestion, to me, it starts from the mouth, because you will eat the food, like you will chew the food, and inside the mouth, as you are chewing, this xylem, there's this saliva enzymes, the xylem that work on the food before they will then be transferred to the stomach, before the stomach enzymes and the like. So that's not what we are here for. So I just try to clear the air that digestion, like digestive tract, actually start from the mouth. So when you are looking at the digestive tract, it's not just the stomach alone, it starts from the mouth. So under the gastrointestinal disorder, now we have cleft lip and cleft palate. So for the cleft lip, this is a defect of the lip, and why the cleft palate is a defect of the palate, characterized by a fusion or a gap in the lips or palate. If you have ever seen a child with cleft lip or cleft palate, at that stage it usually deforms them well. But when the surgery has been done, in fact, except for the few that we just leave, it depends on the severity, except for the few that will leave small mark that will make you to know that like what happened to this person lips. But whenever the surgery has been done, in fact, you won't know, except if you are being told that this thing happened to this baby when he or she was small. So, and type of cleft lip, we have the partial cleft lip and the complete cleft lip. For the partial cleft lip, there is an indentation on the lips, like, I don't know, small indentation, like hole on the lips. I'm going to be putting the picture so that you see everything. While for the complete cleft lip, this can extend up to the nose, to the nostril, and this can be unilateral or bilateral cleft lip on the upper lips. It usually occur to the upper lips, because the upper lips is where the palate and the nose and everything is. So it occurs to the upper lip and not the lower lips. While for the cleft palate, it may affect the hard, the soft palate, or both. It may decide to affect the both palates, the soft and the hard, and it may even extend to the alveoli margin and the uvula. The uvula and the alveoli, they are extended in like they are really deep inside. So for it to be extended to that level is severe. And the problem the baby will be having problem with feeding. At that time, even the mother will be having nipple pain, because the baby will not be able to suck. The baby will not try, the baby will try to compensate. The baby will try to look for a better way to the baby sucking. The baby will try and be chewing, and the baby can't chew the breast milk. So in that, it will with that, it will make the mother to have nipple causes. The causes of this cleft lip or cleft palate is, it can be due to drug, it can be due to genetic problem, obesity, infection. All these happen during pregnancy if the mother is exposed to all of this that I've mentioned. And the treatment for for cleft lip and cleft palate. Thank God. I don't know, again, maybe it is still free, but there are some hospitals they do it free, because they said there are some organization that pump money into that so that they can do it free for the child. So I don't know, maybe it's that the baby has a cleft lip or cleft palate. Please take your baby to the hospital for that. And the treatment, there is a corrective surgery, that is the orthodontic braces that will be inserted. So this orthodontic braces, it assists in straightening and repositioning of the teeth. Repair, it is done between 10 to 12 weeks of, or when the baby is between 10 to 12 weeks. Then the cleft palate is 6 to 18 months old baby is cleft lip repair.